Hi, this is Dr. Burt Bowden. We're getting ready to move on into the third class here, the third module. It's important to understand that we're not quite ready to start doing surgery yet because you got to get a few things prepared before we do that. You have to understand that this is important to do the preparation to get everything ready to do some more understanding about what you're going to do. The mechanics of it actually turns out to be pretty easy, but once you understand all the preparations that are necessary, you'll really kind of go, wow, I hadn't thought about all of that. So let me show you a little bit about what all is necessary that we have to do in order to prepare. So one of the most important things is to understand that you have to have the right supplies in order to do it. You have to have it for your regular phaco surgery. For this, it's going to be the same. Basically, you're going to start out with the regular items from your phaco set. You're going to use your standard balanced salt solution with the tubing that you use with the cassette. You're going to need to pull out of it some blunt Westcots. You don't want to use sharp ones because in this, as you'll understand later, you may rip and tear the conjunctiva. So you want to definitely use blunt Westcots. And then you'll need the speculum, of course, in order to keep the eye open to do the surgery. You normally use your microscope parts. It may be handles, it may be whatever you need to put on your microscope to make it work, but it'll be the standard things. Same drape as you normally use, same viscoelastics as you normally use, and your intracameral lidocaine that you use in order to provide some good numbing inside the eye. Because we're not going to do a block like I do on missions. There, I definitely do a retrobulbar all the time, but you're going to do this just like your regular surgery. You're going to use that intracameral lidocaine. Now, you will need some syringes. The 1 and 3 normally come in a pack, but you may need to add some extra syringes, a 5 for the Simcoe cannula and a 10 for the Vectis. We'll talk more about that. But you'll need your standard paracentesis and slit blades that you have already slit, or keratome blades. You'll need a cystotome if that's what you're used to using. If not, then you won't necessarily have to use it. I'll tell you more about that as we go along, though. You definitely want your cannulas that you have normally used for hydrodissection and for your hydration. And then you want a shield for the end of the case, just like normal. Now, you don't need the phaco handpiece for doing this because you're not going to be phacoing the lens. You're going to be bringing it out whole. You don't need your IA handpiece because a standard one-piece IA handpiece will cause the pressure to go up inside the eye. And with a big wound that you have in small incision cataract surgery, you're going to have that just spraying all over the place as the machine tries to maintain the pressure, and it can't because it leaks all around that handpiece going through the main wound. You won't need your second instrument. You won't need your Utratas unless you're used to using the Utrata and you want to do that. It's preferable to start by just doing a can opener, and I'll tell you more about that. So you don't need a one-piece lens. You want a three-piece lens. You don't need your lens injector or cartridge because you're going to put the lens in whole just as you take out the lens whole. You may need that Utrata, or you can use the cystotome. Either way you want to do is fine, but I would encourage you to try the can opener if you've never done it. It seems like a crazy way, but it works very, very easy. You don't have to have trypan. You can do it on a white cataract. You can do it on a black cataract. You can do it on any kind of cataract, and so you don't have to worry about staining that capsule and tearing it perfectly. As long as you understand how to do the can opener, which I'll teach you, you'll do great and it will work fine. Now, the BSS bag, I do like to put epinephrine in it, and I usually use a half cc of 1 to 1,000. That's like what you use for the asthma kind. If you can, it's nice to find the preservative free, although for years we've used the non-preservative free, and you can also use just 3/10 of a cc in 500. So the zero point 0.5 in 500 is the way to do it. So why do I use epinephrine? I'll tell you why. Because I've seen a lot of people struggle. And when they don't use epinephrine, what happens is they end up using 1 or 2 or 3 ampules of it. And it's not cheap, but the thing is, it's a whole lot easier if you just put it in the bottle to begin with. And then as it's infusing, you've got that epinephrine working for you. It's helping keep the iris under control. And you can use it in all the irrigation in the eye. So, for instance, we're going to have you drawing up some fluid out of the bag, and that will then contain epinephrine. And then you use it for your hydrodissection. You use it anytime you're in the eye. That will maintain exactly what you need in there to keep that pupil nicely dilated. You can also use it on the eye, so you can just put it in a syringe and irrigate, however you use BSS to wet the cornea, as we constantly say. So instruments are really important. You're going to have to get some extra instruments, just a few though. And the real determining factor is how fast can they do a turnover, because in some places they can do them and they have a statum and it can take like 10 minutes, 5, 10 minutes. Other places it's an hour. So that really determines the number of instruments that you need to have, but you'll definitely need at least 2 sets, because if one set breaks or you drop it or something like that, you're out of luck. You can't do any more cases. So you definitely want at least 2 sets. And you may want more depending again on the turnover time and how many of these small incision surgeries you plan on doing. So besides that, you need to add some things to the case. Now, on the previous episodes of this, I've talked about the things that you need to buy, and I've got a handout that's available with the second masterclass about what all you should buy in order for the extra instruments and supplies. So you need those things. You'll also need a cystotome if you don't use a cystotome normally. You'll need a 10 ml syringe, 10 milliliters, in order to help with the bringing out the lens out of the eye. It helps a lot to use plenty of volume because you're using a hydraulic force that's bringing the lens out. You can get away with a 5 or a 3 probably, but to start with, I'd start with a 10 to begin with. You're also going to need a 3-piece lens. Why do you want that? I'll tell you about it in a little bit, but you're going to want to get rid of your 1-piece lens, your foldable lens. For this case, you want to use a 3-piece lens, and you want to get some gauze, Q-tips, and your eye patches, because after you've done all the work on the eye and the conjunctiva and cauterizing, you're going to want to patch the eye at least for several hours until you see them in the afternoon or you see them the next day. That gives them a little bit of extra time to help it to heal. That's different from what you need to do for a regular phaco. So the lens is the 3-piece. The beauty of it is you can put it in the sulcus or in the bag. So I only on missions have 3-piece lenses. That way, whatever happens, if there's something not quite right about the capsule, I can put it in the sulcus. If everything goes fine, I can put it in the bag, and it works great. It's no problem. But if you only have one type of lens on missions, that's what you want to get, and that's what we do. It definitely holds better, and it'll stay in the bag, uh, especially when you do a bigger can opener Rexus. If you're doing your standard Rexus, I wouldn't advise it, and I'll tell you why later on. But if you're doing your standard Rexus and you go ahead and put some relaxing incisions in there, any kind of lens probably will work, but a 1-piece can come out of the bag if you don't do that CCC, the continuous curvilinear capsulorhexis. So think about how you want to do this, and you may have to get some lenses of different amounts. And there's 2 different ones that I normally use because I can get these on missions. The Alcon MA60AC is a real good 3-piece lens, and the Bosch and Lohm also makes an LIO lens that works really well. These are nice 3 pieces that you can have in stock ready to go for the proper power that you need. Especially if you convert, you're going to need to convert and have a different power of lens in most cases if you're going to put in one into the sulcus. So anyway, think about that and think about getting 3-piece lenses. The crescent blade you need, I told you before, don't get the one with the green handle. It's too sharp. And I'll show you in a picture too in one of the videos about how it really works. You want to get the clear cut or the AOK crescent. Either one of those works fine. That's from Alcon. You can get other brands, of course, but you really don't want the super sharpest thing out there because you need to have a little bit of relaxing capability, whereas like if you had a diamond knife or you use that green handle crescent, you might cut through a whole lot easier and a whole lot quicker than you expect to. And then the plain AOK crescent from Alcon is just right. It makes it very good for learning. You're going to need an irrigating vectus, and that allows the hydraulic lens removal. So when you're using that, you can take it out, and it's not done by pulling the lens out. It helps you hold the cataract, and then you remove it and guide it out with the irrigating vectis as you're using hydraulic forces and pushing posteriorly on the lens to help open the tunnel to help bring out the lens. It's really very straightforward, but you need an irrigating vectis to do it. A lens loop will tend to work, but you tend to drag it out. So I like to put water in, put BSS in as I'm removing the lens, and an irrigating vectis is the only way to do that. A lens inserter is nice because it allows you to insert the lens vertically. So you hold this in your hand and you can see the tips of that lens inserter would go across the optic, and one of the haptics goes in also in the jaws, and then you insert it. And that allows you to go straight into the wound or the incision opening. With that, it's real nice because it goes the way your hand tends to go. If you use the McPherson's to do it, you can also insert it, but you have to hold your hand horizontally, and you have to work in a little bit different way than you're used to put it into the eye. So the lens inserter makes it real nice and simple, and I then combine it with the McPherson as the next step for inserting a three-piece lens, and I'll show you the trick how to do that. You need a pencil tip cautery, and you got to have the right kind. Don't get the retina kind, the 25 gauge kind, because they'll just stick to the sclera and they don't work. You need these that are truly a little bipolar cautery, and you can see the curved tip or the straight tip. Either one is good for cauterizing. You can use the ones that are like pickups or that are like tweezers. They have different kinds, but these are ideal because they just allow you to just paint the conjunctiva and sclera, and you can do whatever you need to with them because they work as a good bipolar. Now, the cautery cord also connects there to your phaco machine. Now, you probably have one at the hospital or at your surgery center. If they do any other kinds of surgeries, there's many times those cautery cords, so they don't really have to go searching for those, and they'll go, oh yeah, we've got those for all kinds of other surgeries. The bimanual IA is really important because, like I said before, a single piece IA that you're used to using will just squirt right out and it'll blow BSS all over the place, as I've discovered. So you have to get a bimanual to use. That's why there's also going to be two paracentesis. I'll show you that. But you can get a disposable bimanuals from Alcon. They're easy to use. You can get them sterilizable also from Pakistan, from the U.S. I'll show you the stuff from a guy that I order things from. We occasionally need a Simcoe cannula if you don't have a phaco machine, and that's so if you don't have it, use it for missions. But guess what? What happens if your machine breaks? You got to have something if you're in the middle of a case to finish the case. So a Simcoe can be a great rescue you if your machine breaks or something happens. There's also a little handle that you can get from Alcon, and it makes it more like a pen so that you can use it to hold the Simcoe better. And you have to be careful to get a good one because you can buy them, and I've bought several from the States, but they weren't so good. I found a gold one time, and I said, oh, this is going to be great. But the tip on it was a mess. It had burrs on it, and after my fourth uh, posterior capsular rupture of the day, I decided it wasn't worth it, and it turned out to be. It was that Simcoe cannula. So you want a good cannula. There's the blue tip there that you can see. You want to insert that into the tip there at the bottom, and then you use a suction that you create yourself with a syringe. Typically 5 is good. You can use 10 also to help, and so you'll be constantly irrigating through the blue uh, handle from just your regular bag of BSS that goes into the eye irrigating. Then your aspiration is through the tubing, and it aspirates out the cortex after you've removed the lens with a small incision. Now I like to use a special kind of forceps as I'm doing this. So I had call them the Bowden forceps. He does anyway. He named them that, but um, they're a large Calibri style forceps, and it's good because the small little Calibris you can't hardly hold. Well, I can't hold in my hands; they're too big for the little Calibris. But they have small teeth, point 0.3 teeth, a little bit bigger than the regular 0.12s, but they're fixation forceps. And the fixation forceps are angled at 45 degrees in order to grab hold of things and hold it very still and perfect. So the fixation forceps allows you to grab the sclera, grab the Tenon's handle, use whatever in order to control the eye and make it just right. And you can't find them in the US made like this. They typically have a 90-degree angle to them, and that doesn't allow you to grab things the same way. So here's a little video he put together showing these forceps. They're round handled, makes it easier to just use your fingers to twist them. You have the tips there that are close. You can see they're 45-degree angles. And the Calibri helps you get away from what you need to so you can see under the microscope instead of having your hand or the 0.12s right in the way. So, how do you order those instruments? Well, you can get them from my friend Shiraz. He's on Facebook. You can look him up that way. He's in Pakistan. This is his email, and there's his WhatsApp number. So you can just contact him. He knows that there might be people contacting wanting these things. And his instruments come as you can buy them individually, of course, but he gives you a bimanual set, 2 Simcoes, 2 irrigating Vectis, the lens insertion forceps, the Bowden forceps, and a small sterilization box, and that's all together $500 shipped to the United States. And so there it is. You can buy them individually. You can buy those bimanual handles. You might be able to get that. You can look around and you can find disposable Vectis. They're hard to come by, hard to find. The lens inserters you can find, pickups similar you can find, but these are all designed specifically by me, having used lots and lots of different instruments and tried lots of things. Now, the 2 Simcoes that come with it also aren't shown there. But here's something that's important to understand. What we're trying to do is so that you can understand all the extra stuff so that your tech can lay everything out they need. This is one of the ladies that worked with me. She laid all these things out in order, labeled them, and did everything that's necessary for a small incision. It's actually not what you'd be doing exactly if you're going to be doing a one with your phaco machine, but it really works well for them to understand. And you've got to be working with them. You've got to go over things with the tech. There's a handout that I put out that's part of this same module, and it tells them all the steps down all the way through each individual steps. It gives a list of the instruments to add. It gives them a list of the instruments to take away. And they got to understand some things that you won't have to think about. The Westcotts do move, so you use the Westcotts at the beginning to open the drape, and then you use them again when you're going to open the conjunctiva. So they have to move in the sequence there. So you'll need 4 syringes too when you're doing a small incision. If you add and convert, you're going to need to add those syringes also. You're going to need the crescent, the paracentesis, the crescent blade, and the slit or keratome blade. So that's just like normal. But you got to teach them. They are going to be your ally. The circulator is going to be your ally because she's going to be the one getting you these things when it's time. And you say, oh, we got to convert to a small incision. She'll know where that box is that you can grab that has all those extra items in it. And you'll be able to do what you need to. They'll help you remember exactly what you need. And remember, you're a team. You may choose one tech, one nurse to learn how to do this with you, and that's probably the best way to have someone help you out with this. Now, when you get back to the office, you got to find some patients. You got to start be thinking about this when you're going to be doing it. As you're gathering the supplies, you got to be gathering the patients too. So you got to find some good patients for small incision. The ones that'll be good to start with in your clinic that you'll find is those patients who are at least 2+ nuclear sclerosis, but not 4+ yet. You don't want any of the super hard ones. 4+ might be okay, but you don't want any fussy particular patients. You want your general run-of-the-mill patients that you have, not your patients that want a premium lens for sure. You don't want to do that initially with them. So think about it that you want them to be able to go have a monocular lens, so only those who can take a three-piece lens. And you may want to discuss it with them. Say, hey, I'm doing this new way of doing surgery. It may take a little bit longer. We're going to do it a little bit different, but you'll see just the same afterwards. But I'm going to do it with a little bit different technique than I have in the past that allows me to prepare for those people that need it for very hard, difficult cases. So you may want to discuss it with them and tell them, or you may choose not to and just do it. But that's up to you to decide to do that. Just remember that any dark black or white cataracts, you're not ready to do those yet. So don't choose those to begin with for your first cases. Do about 15 regular patients in the 2 to 4 plus nuclear sclerosis, just because you want to get uh, your feet wet. You want to get used to how to do this procedure. You want to have your helpers ready to help you. You want to have gone through it several times, since repetition is the key to adult learning, and you're not ready to start diving into really difficult cases. So make everything as easy and simple as possible to begin with. Find those patients that you shouldn't have any trouble with. You should be starting to think about a tentative date for the first time for you to do these. And the way I like to kind of think about doing it is maybe start with 3 days of 5 patients where you're doing small incision surgery, and then half of your regular phaco patients. So if you normally do 20 phaco patients a day, do 10, and then do 5 after that of the small incision patients. You don't want to start with the small incision. You want to get warmed up. You want to get everything ready. You don't want a small incision to be the first case of the day on your first day trying it. You want to try and do what you're used to, and then you're just going to add to it, and then it makes it a whole lot easier for you to do it that way. After you've done about those 3 days, then you can do 2 days of just 10 patients of small incisions and no phaco. So that gets you up to 35 patients right there, and you should be able to be doing things pretty well by that time, because repetition is the key to adult learning. And it's very important because you repeat and repeat and do it for you, the techs, and the circulator. The first case is always going to be slow. The second case is slow, but as you get to the 10th case on those days, you'll be having no trouble at all. They'll know the routine and you'll have it down. And the second day of doing 10 patients like that, then you'll know how to do it. Then what you want to do is start looking for those patients that have harder and more difficult cataracts. And so now you've got a few action items that you have to take. These are at the end, of course, and I want you to think about, have I got the proper instruments? Do I have the instruments that I need? Do I need to order some instruments? Make sure you've got all the supplies, and be sure and look at those handouts. And there's a list of the items that you need to order, the list of the instruments you need to order. Most important is really make sure your tech and circulator that are going to work with you on this, they're ready. They should be getting ready as you're getting ready. They can watch this, they can read about how to uh, get the instruments read together, do everything that's necessary. A lot of this does apply to them, and so I want you to know this is just not for you, but it's for everybody, for your team to come together to make it right. So thank you, and that's the end of this third class. And next one is going to be how we actually start doing surgery. See you soon.